Welcome, everyone. We want to thank you for joining today's webinar from Setup to Treatment, Improving Clinical Workflows for SRS and SRT and Head and Neck Positioning with 6-Stop and Halcyon. We are pleased to have two experienced clinical teams with us today to share how they have improved setup consistency and workflow efficiency by incorporating the TruPose Head Adjuster into their daily practice. To begin, Umar Baharam will provide an overview of the TruPose Head Adjuster and highlight its key advantages for clinics. Next, Dr. Adi Robinson from AdventHealth Celebration will discuss his team's workflow using TruPose on a TrueBeam system equipped with a 6-stop couch and SGRT system. And finally, Daniel Nguyen from ORLAM Group will share his experience implementing TruPose on the Halcyon platform. He will cover workflow integration, setup reproducibility, and helpful tips and tricks for forming an open face mask. Just a reminder that today's webinar is recorded. You will get sent a recording after the presentation. And if you have any questions for our presenters, please make sure to use the Q&A at the top of your screen, or please submit them through the chat and we will address them at the end of the presentation. Thank you so much. And I want to hand it over now to Umar.
Thanks, Ashley. So before I pass it on to Adi and Daniel, I'm just gonna give you a quick kind of overview of the TruPose Head Adjuster. So this is a 3-degree of freedom head adjuster for head and neck and SRS patient, for especially if you don't have full 6-degree of freedom adjustment. And it kind of works hand in hand with SGRT system, to kind of position your patient. So just kind of obvious overview on the SGRT system. I'm sure a lot of people are familiar with this. So for SGRT, there are cameras mounted on the ceiling, kind of monitoring the surface of the patient. It can be used for patient setup and also monitoring patient position during treatment as well. Kind of see here, you can set up your ROI. You can kind of see, for the face. I mean, it can be used for other kind of body parts as well. But for this application, it's going to be for the head and neck and SRS. And most system will show you the deltas, and there's tolerances that you can check the set for each treatment. And in terms of the SGRT system, these are the ones that are available. Vision RT, Line RT. There's also the variant identifier as well. For the TruPose Head Adjuster itself, this is the kind of the anatomy of the head adjuster. There's a base plate that can be indexed with the indexing bar. And then there's an adjustable head plate, and then there's the mechanical housing. In the mechanical housing, there's these knobs that are color-coded. We have roll in red, pitch in green, and then yaw in blue. There's also indicators as well to show your adjustment. Like I said, most of the adjustments are going to be done with the feedback SGRT system, but you also have these kind of indicators that you can use. In terms of the range of motion, for roll, you have ±4 degrees. As well as yaw is ±4, and then pitch is ±3 degrees. In terms of mass system compatibilities, there are 3 that we currently have. There's the 5-pin S-type, and the Orfit 3-point high precision, and the Micromedics dual shell position system. And also, if you are using kind of the Encompass system from CQ Medical, you can just purchase the adapter that would fit on the Type S system. And then for CT simulation only, you could use the TruPose Static, which kind of has the same geometry as the TruPose Head Adjuster, but it does not have the ability to do the adjustment. So they'll only be used for your CT simulation. Again, we have it in 3 types to match your TruPose Head Adjuster. So yeah, that's a quick overview of this. So I'll pass it on to Adi for his presentation.
Thank you, Omar. I'm going to talk about our clinical experience with the TruPose Head Adjuster, and as Ashley said, we used it primarily on our TrueBeam with a 6-stop couch, and an SGRT system. What I wanted to kind of start with is, we all use thermoplastic masks. We have index headsets, lasers, image guidance, and all that stuff. And that's really great for setting up the patient. But the issue that we sometimes see is reproducibility. The reproducible posture, especially when we are looking into positioning the shoulders, neck, and head, can be difficult. So we've seen plenty of times where a patient can be correctly indexed while the head remains slightly flexed or extended or rolled or rotated relative to the body, and it does not match what we had in sim. And the therapists that are setting up that patient, they obviously recognize it and they see those rotational differences, but they have very limited correction options. So the clinical question is how can we fix the head relative to the shoulders and neck without resetting up the whole patient. So taking off the mask, repositioning the patient, putting the mask back in, and so on and so forth. Utilizing surface guidance, we can definitely detect that there are any residual translation or rotational issues. And the surface guidance gives us immediate feedback about that from a reference surface, which is usually what was simulated. But we don't need to physically move the patient. We have those numbers. So again, as I mentioned earlier, traditional corrections would be to manipulate the patient, reset the mask, reassess the surface, and then repeat. But with TruPose, as Omar showed a couple slides ago, we can apply the controlled mechanical adjustment of that head under a live surface feedback. So we can correct those 3 degrees of motion while looking at the SGRT feedback, get them into where we want them to be, and then verify with IGRT. And we can repeat that process. So if something happened, the patient moved, or the IGRT came back with internal anatomy not really where we want it to be, we can go back, make the adjustments again, and then verify again. So a quick review on the TruPose. It has the flexible base with adjustable head plate incorporated into the compatible thermoplastic mask workflows, as Omar showed. We have those 3 external controls that allow for pitch, roll, and yaw changes. And I think the clinical value here comes from combining that mechanical movement with real-time SGRT feedback, so you can observe that values, adjust, and then continue on with your workflow. So as the workflow that we kind of implemented is, observe the residual SGRT rotation, select the appropriate axis to change. You adjust that live while looking at those delta, getting better, and then convert to your setup tolerance and verify. So integrating it into your workflows, is the challenge here, but it's not really a challenge. If you want to use TruPose for that specific treatment, then you just have to include it in your CT simulation. Set the mask, the headrest, the base plate, indexed and all that, just as you would do with any other mask, and then scan it with the device so it will carry it into the plan. When you're treating, you want to reproduce the indexing, use the usual SGRT procedure as you've using before for translational motion and overall posture, but then use the TruPose to fine-tune your pitch, yaw, and roll. And then once your surface is within your departmental criteria, you can move on to internal anatomy verification and then final couch corrections. What we can't forget is once we made all these corrections, we have to reacquire the SGRT surface for future use, such that the next day the adjustments in the setup will be more reproducible and easier to do. So in basically 6 steps, we can achieve this SGRT, IGRT, TruPose workflow. And what we did is we took a selected clinical case evaluation. So we picked 25 to 30 patients, and we actually selected them. It wasn't randomized or anything, and it encompasses about 250 fractions. We had 5 therapists that are experienced in positioning participating, and we predominantly chose head and neck because of the region and the difficulty of setting up, but we did test it on a few SRS cases. So, our clinical setting, as was mentioned, we have a TrueBeam Align RT, thoroplastic mass setup, and TruPose at sim and treatment. What was the consistent feedback that that was associated with the therapist effort and predictability? They reported that the device was very intuitive, and that the correction behavior was more predictable. So you basically turning a knob, knowing that you're going to move the patient that way or that way, and you can kind of see it with your SGRT, which made it super easy. And setup times or correction cycles and all that, we didn't really formally measure it, but in a qualitative sense, we did observe efficiency gains, dramatic efficiency gains when it came to difficult setups. So it was really minimal disruption, very intuitive. You get a lot more control on your setups and confidence before CT with the combination of your SGRT and the TruPose. So again, we didn't have to manipulate the patient or the mask. The response was right away, and there's no physical effort into it. So super useful. And some numbers, since I'm a physicist, looking at some delta changes in rotation pre and post use of TruPose. So looking at the mean absolute SGRT pitch, we decreased it from about 2.2 degrees to a half a degree immediately before CBCT. The roll went from 1.8 to 3/4, and the yaw went from almost 1 to 0.8. So if you're looking at the root sum square of all the rotation components, you can see that we went from about 3 degrees to a 1.24. And that's those are characterized by the observed workflow. So this is what we saw as we were doing these improvements, and it's a significant caseload, so it definitely can be extended to most workflows. So almost 60% overall reduction is amazing for efficiency and reproducibility. Again, I want to make sure that the surface setup does not replace CBCT, so you still have to make that correlation between internal anatomy and external anatomy. So looking at our residual CBCT corrections, we had a 2.1 vert, 1.3 long, and 1.2 long, which is super small in millimeters, and then very small rotation corrections as well. So with the TruPose, we get a better external surface starting point without compromising any internal anatomy verification. Some people might say or think, and I was one of them, that with a 6-DOF couch, you don't really need any head adjuster. You can just correct everything in 6 degrees. But the issue that we found is that the 6-DOF couch rotates the entire patient, and between the shoulders, the neck, and the head, you have multiple different axes of rotation. And those need sometimes to be adjusted separately. So what we have with the TruPose is a complementary action. A couch cushion can be aligned to the register target while preserving a difference in head, neck, and shoulder posture from simulation. And that's what TruPose is intending to do. Help you make the patient's positioning as close as possible to what it was simmed without any kind of compromises. So Daniel's going to talk a lot about the bore-based stuff, but there is some limitation there with the 6-DOF corrections. But on CM, with our experience, some CMs don't have 6-DOF degrees, and then the head pose adjuster would really be useful there. But as I said before, even without it, it is great. So in order to build into your pathway, we kind of followed these steps. We got to make sure that we simulate with that device if we are planning to treat it and record the indexing position. We define protocols with ROIs and tolerances on the SGRT side, and how to fix the adjustment sequence. Kind of rule out when we can use it and when we cannot. Obviously, we did some training on how to control the axis by axis stuff and some documentations on it. We performed verification with CBCT and registration, and we also QA'd the device to make sure that if there's any transition through it and kind of motion and travel checks and all that stuff. Once you do all that, I think it's clinically ready. And just for disclosure, some limitations on our study. Our evaluation supports feasibility and qualitative workflow observations and descriptive changes in SGRT rotation values. We didn't really look into accuracy or reduce setup times and stuff like that in a more quantitative state. But as I mentioned before, we did see improvement in our workflows. It was more intuitive. It was more straightforward. And it was simpler. So kind of as conclusions, I think combining those three modalities, SGRT, IGRT, and the TruPose, we can see the residual rotations that need to be made. The corrections can be done with the TruPose, and then we can verify it with the IGRT. And the goal here with the TruPose and SGRT is to improve the pre-imaging starting point and not replace the imaging altogether. So with that, I want to thank you. And if you have any more questions, save them for the end, and I'll pass it on to Daniel.
So thank you for your invitation to let me the possibility to share my experience with the TruPose. So today I will present the added value of SGRT and the TruPose for Halcyon machine. Before I start, I would like to mention that ORLAM collaborate with the VisionRT and Standard Imaging, but the opinions in this presentation are entirely my own. So the ORLAM Group, we have 4 radiotherapy centers, 3 localized in Lyon and 1 in Mâcon. All of them are localized in France. After installing the Halcyon machine, as you can see, we have some Halcyon machines in our centers. And we have 1 TrueBeam Edge. They are installed in 2018. And Meridian in 2023, we treated more than 1,000 patients with the Meridian machine. And this year, we are installing the new system from United Imaging, the online platform offering an adaptive workflow with TrueCT scanner. Under this system, we will also integrate the full VisionRT solution, AlignRT, MapRT, and OZRT, and maybe we will make the similar workflow like ADI. Maybe we will use the TruPose with this new machine. So why in-body changes everything, unlike conventional SGRT, where camera occlusion can occur due to the gantry rotation and imaging components, the in-bore system maintains continuously visibility of the patient surface throughout treatments. And this enables true real-time interaction monitoring and continuous verification of workflow reproducibility. Why SRT on Halcyon with AlignRT in-bore? As you know, SRT is the gold standard for brain metastases because it's precise, conformal, and sparing healthy tissue. However, the Halcyon system, so efficient and well-suited for cranial treatments, lacks of a 6 degree of freedom couch. Without its rotational setup errors, pitch, roll, and yaw can't be corrected directly, which is a limitation for stereotactic accuracy. Here you can see previous work published by Lee et al. They demonstrated that Halcyon can successfully deliver intracranial SRS and SRT treatments Their study showed a good target conformity, acceptable dose gradient, and an efficient coplanar remote workflow, supporting the clinical use for Halcyon or for brain stereotactic treatments. Also, Palisi et al. Published this year in Physica Medica, and she found a similar result compared to Lee et al. So we want to know to see if using SGRT, an open face mask, and the TruPose Head Adjuster can achieve the same setup accuracy as the TrueBeam with a 6 degrees of freedom couch. But before to treat the patient, the most important step of the whole patient workflow is for the especially for the intracorneal open face mask. We need to mold the mask that the chin should be slightly lowered to ensure optimal SGRT visibility, unlike for example AD head and neck setup. The mask must be fully dry before CT simulation to avoid any deformation during the treatment. And to do this, you can use the cold hair drying. Can help you to stabilize the key areas such as the chin or corneal region for better immobilization and reproducibility. Here I want to show you the influence of the 3 regions of interest on the intracorneal stereotactic treatment. In this first image, we can see the alignment in the AdventHealth software with the type 1 region of interest on a rigid phantom. The translation values are out of tolerance here because I positioned the mask and used the head adjuster system to fine-tune the rotation values. Now the region of interest number 2, as you can see, the surface is smaller, but the rotation values remain virtually identical to those from the first one. This shows that the system rotational alignment is not affected by the type of region of interest. And finally, the last one, the last region of interest, it is smaller than the 2 region of interest 1 and 2. And as you can see, the rotation values show negligible variation, and the translation values remain consistent. And this confirms that the type and the size of the region of interest have negligible impact. This behavior is likely explained by the absence of gantry-related occlusions and the favorite camera geometry of the bore-mount SGRT system, which allows robust surface reconstruction across different facial region of interest definition. These findings differ from the C-arm, like Adil talked previously, where regional interest selection can play a more pronounced role in tracking stability due to the limited camera perspective and partial surface visibility. So, as here under this picture, you can see the TruPose on the Halcyon machine. So it allows simple pitch roll and yaw adjustment as Omar and Adil explained previously, with only 3 color code knobs or so with a safe rotation range, and it's worked with all common mask system. Here you can see how easy it is to correct rotational error in real time. You can see the therapist turn the knobs and with the AdventHealth values to correct rotational errors to be close to 0 degrees. This figure shows the AdventHealth recording for the 3 rotational axes. Using the TruPose system, we were able to correct the rotational deviations and bring them close to 0. So here for this case, the corrections were achieved very quickly in less than 20 seconds. So the practical workflow, the workflow is built around maintaining geometric consistencies from CT to treatment, SGRT deltas directly guide the rotational adjustment with immediate visual feedback, as you can see previously. And after CBCT, you can adjust with a small additional adjustment by using the TruPose. For the study, we create three different groups. The first one, 24 patients treated from March 2023 to October 2024 using SGRT only workflow. And the group B, we selected 24 patients treated from October 2024. We use SGRT and the TruPose system. And finally, the third group, 24 patients treated with the TrueBeam and the Encompass mask, and with the 6-degree freedom couch. And we use residual rotational error to compare. Here, the result, you can see that the results show SGRT alone performs well, but the addition of TruPose Head Adjuster significantly improve rotational precision. And with TruPose Halcyon approach, TrueBeam level accuracy, reducing average residual rotations below 0.5 degrees. Here, an example of the patient after CBCT acquisition and after the online matching. As you can see, although the head adjuster position is slightly different because we use the knobs to adjust manually. And if we focus on the skull position, you can see that it is identical between CBCT and CT, confirming accurate immobilization. So SGRT gives us stable cranial tracking, and TruPose let us correct rotations quickly, and you usually keep them under 1 degree. This maintains good agreement from CBCT to beam on, especially on ball type Linacs without 6-degree of freedom. And even with Halcyon 5 and the perfect kinetic couch, this fine manual adjustment remain useful to reach the sub 0.5 degree alignment before imaging. So to conclude, in summary, SGRT provides accurate rotational information that could be corrected reliably using a mechanical adjuster. This workflow integrates easily into existing SGRT-based intracranial process and could be adopted by centers using bore type Linac. Thank you.
Awesome. Thank you so much to Umar, Addie, and Daniel for sharing your time, your expertise, and those valuable clinical insights with everyone today. We appreciate the perspectives you brought in improving consistency and workflow efficiency. So we'll now move on to the question and answer portion of today's webinar, and we can address the questions that have been submitted. So just grab those. There's a few I saw that came through in the chat. This one is for Dr. Robinson. Can you share what your therapist's learning curve and proficiency and the proficiency timelines?
I think the learning curve was pretty exact. I mean, maybe it's my bad style, but I kind of throw stuff at them sometimes just to see how well they can integrate it, obviously with not putting the patient at risk. But I think we went over it at sim a couple of times and practice on our own, but it's super intuitive and the learning curve is really, really fast. So putting on the patient, maybe at first you don't know what clockwise rotation means, but you pick it up right away. And I think it's super easy to use and super intuitive. So I think within a couple of patients, they already got the hang of it and we were running with it.
Amazing, thank you. The next one is, can any of the presenters share which cancer types show better post-treatment prognosis based on the treatment accuracy?
I mean, I think that's hard to tell. You can't pinpoint it just based on that, because even without the TruPose, we have the CBCT and SGRT, so we can, we will never treat a patient that is not accurately positioned. But I think it makes things easier for the therapist and the patient because they don't have to spend that much time setting up the patient, especially patients that are in pain or have mask discomfort. And we're not compromising on any accuracy or plan quality. So that's how I would answer this question.
Wonderful,
Yeah.
thank you. And it looks like our last question here, it says, both presenters have high volume of head and neck cancer patients. Will these workflow efficiencies be meaningful to my smaller community hospital where they treat about 2 to 3 patients per week? How do I convince my director?
It's all about, I don't think it matters if you treat 1 patient a week or 15 patients a day. I think it's we're customer facing. We want to give the best treatment for our patients, and we want to make it. If you only have 4 or 5 head and neck patients a week, but you still have other patients. So, making the setup efficient, making the setup accurate, making the setup reproducible, I think it's key regardless. And, by using it on those few patients, you might find uses for other locations, not necessarily maybe just SRS brain, but also just whole brain in general and other kind of setups that are above the shoulder. So it has multiple uses for it, so that I think is justifiable for you to at least try it.
Yeah, I agree with Adi. That is why I will maybe acquire another system for the new machine from United Imaging, and they will have a 6 degree of freedom couch. And our mission is to provide the best treatment for the patient. So.
Wonderful. Thank you for both those answers. I think that's all I'm seeing today. So we'll just wrap up here. I just wanted to give another thank you to Umar, to Adi, and to Daniel for the wonderful presentations and sharing all that information with us. We'll send out the recording in the next few days here, so expect that in your inbox. And thank you so much.
Thank
Take
you.
care.
Yeah, thank you.
Yeah, bye-bye.